Hello, my name is Niyati Patel, and I'm a third-year medical student at Nova Southeastern University. Today, I will be presenting a case called colon cancer presenting as acute appendicitis. Before I begin my presentation, I would like to thank my colleagues Anvit Reddy, Anthony Araños, and Dr. Oyoki. Colorectal carcinoma is the second most common cause of cancer-related deaths. About 25% of cecal adenocarcinomas present as acute appendicitis, with 62% of those going undiagnosed as a cancer. This delay in diagnosis can lead to both poor outcomes and complications. Our case includes a 66-year-old active male who presented to the emergency room with no significant past medical history. His chief complaint included persistent and worsening right lower quadrant abdominal pain that had been going on for 6 weeks. He denied any flu-like symptoms, nausea, vomiting, diarrhea, weight loss, stool discoloration, and changes in bowel movements. Patient denied the use of alcohol, tobacco, and illicit drugs. He had no family history of colon cancer and never had a colonoscopy done. Upon admission, the patient's vitals and labs were within normal limits. A focused physical exam included tenderness to palpation in the right lower quadrant, negative psoas and Rosing sign, no rebound tenderness, no guarding or abdominal distension was noted, and bowel sounds are present in all 4 quadrants. The CT scan that is shown on the right-hand side showed an enlarged, fluid-filled appendix surrounded by inflammatory changes. Because of the CT scan and the classic location of the pain, this patient was diagnosed with acute appendicitis. Before surgery, he was treated with sulfoxetine, metronidazole, and lactated ringers. The surgeon decided to do a hand-assisted laparoscopic appendectomy with bowel exploration to rule out possible underlying causes such as malignancies or polyps. During surgery, a large polyp-type mass was found in the cecum. Both the cecum and the appendix were resected and sent up to pathology because the surgeon had a high clinical suspicion of a malignant mass. Preliminary pathology results showed that the polyp was most likely malignant, and because of this, a right-sided colectomy was performed and a functional anastomosis was formed between the terminal ileum and the transverse colon. A couple days later, the final pathology results revealed that the mass was a grade 1 well-differentiated cecal adenocarcinoma. With colon cancer presenting as a common benign process, it is essential to consider it as a differential diagnosis even in individuals who may not traditionally be considered high risk. High-risk individuals can include those who consume a lot of alcohol, smoke, tobacco, those who are obese, and those who live a very sedentary lifestyle. Appendicitis presenting in any individual greater than the age of 40 should raise high clinical suspicion for the possibility of malignancy. The pathophysiology behind this and the potential factors that can be contributing to the appendiceal inflammation include obstruction of the appendiceal orifice by a mass, pressure buildup secondary to a distal colonic mass onto the cecum, and inflammatory changes within the cecum that eventually lead to obstruction of the appendix. This case shows us how a strong clinical suspicion can dramatically change the approach to treatment and improve prognosis. Rather than performing a routine appendectomy, this patient's cancer was identified and resected at its earlier stages prior to metastasis because of the surgeon's high clinical suspicion. Thank you.